Thanks for joining me here today for the first part of our lecture on Chapter 8, Medications for Mental Disorders. Our goals for this series of mini-lectures are to discuss the medical model of mental disorders and some commonly diagnosed disorders. We'll talk a little bit about the history of treatments for mental illnesses here in the United States and around the world, and then we'll review some of our current drug-based or pharmacotherapeutic approaches. So we're going to start by talking about the medical model for mental illness. So if we're going to talk about the medical model, think about what happens when you go to the doctors for maybe the flu or an upper respiratory infection. You're not feeling well, you go see the doctor or another healthcare provider. The provider assesses your symptoms, moves towards a diagnosis, figures out how it was caused, which helps them come up with a treatment, which then can help them to deliver a cure. So there's some real criticisms about using this particular model to address mental health. And basically it's because usually the only symptoms that we can come up with at very first stage are behavioral. And behavioral symptoms are widely varied. They're going to be difficult to diagnose because of that variation from person to person, and they can have lots and lots of different causes. So despite the criticisms of this model, it does underlie most of our current thinking and honestly our pharmacotherapeutic approach to addressing mental illness. So we're not looking into circumstances or surroundings for the person exhibiting the behavior. We're looking within the person themselves for a medical physiological issue causing the mental disorder. So we're looking for chemical imbalances that we can treat with specific drugs. And there's some real criticism of using this particular approach. Regardless of that, though, it is the primary approach that we use here in the modern era for addressing and treating mental illness. And the way that we diagnose those, moving from displaying symptoms to diagnosing, is through the DSM, or the Diagnostic and Statistical Manual of Mental Disorders. So this is a fairly current update, the DSM-5, to this manual, which is developed by the APA, or the American Psychiatric Association. So it basically provides the diagnostic criteria, or the lists of symptoms that are associated with hundreds and hundreds of disorders. It is a really widely used classification system, both in the United States and similar systems around the world. And this is where we get a list of the symptoms that would lead to a professional diagnosis for anxiety, for psychoses like schizophrenia, and for mood disorders like depression. So the list of symptoms and perhaps the number that a person needs to be displaying in order to be diagnosed with a condition are listed in this manual, published by the American Psychiatric Association. When we talk about the kinds of disorders that are profiled in the DSM, some of the major categories include anxiety disorders. And those are, if we think about general feelings of anxiety, those are pretty easy to understand. Talking about worry, fears, or avoidance, but this would be excessive. So it becomes a disorder when it's excessive worries, fears, or avoidance of certain conditions or circumstances. Some of the anxiety disorders that are profiled in the DSM include social anxiety disorder, panic disorder, and these can be truly debilitating conditions that truly affect a person's quality of life, different from that level of general worry or fear that most people feel from time to time. Another category of mental disorders included in the DSM, psychosis, and these are truly serious mental disorders that involve losing contact with reality. A good example of this would be schizophrenia. So if we're looking to diagnose schizophrenia, what the psychiatrist would be looking for is chronic psychosis, or chronic serious mental disorder, characterized by two of the following, including at least one of the first three. So this is that list of symptoms: delusions, hallucinations, disorganized speech, disorganized behavior, lack of emotional response. So we're looking for at least one of the first three: delusions, hallucinations, or disorganized speech, and then at least one other. And then also the condition that would cause significant interference with social functioning or functioning in a job setting. So you can think about how kind of general that is, that significant interference with social or occupational functioning. Could mean different things to different people. Kind of we know it when we see it, and if somebody's has a serious mental health issue, we can see that there. But for people who might be kind of in between, not that schizophrenia is a great example of this, but for other mental disorders, you can see how the idea of using that medical model to diagnose might be difficult, because we don't have the kinds of clear data that we can get with more physiologically based disorders. All right, so another category of mental disorders would be mood disorders, and this is where we see depression, bipolar disorder, diseases that are characterized by being depressed or being manic. And we often find that individuals don't fit neatly into just one of these diagnostic categories. They may have a comorbidity, they may have more than one mental disorder, and they may have important serious mental health symptoms that don't necessarily correspond to one of the categories. So some of the problems with using that medical model, although it is the best course of action currently available in the United States. So when we talk about how mental disorders were treated in the past, we've got some interesting and unique approaches. One of the major causes of mental disorders in before the first half of the middle of the 20th century was general paresis. So general paresis results from late-stage syphilis, untreated syphilis, and it causes an infection of the nervous system that in turn causes psychosis. There are estimates that at the height of that actually not during the early 20th century, that about fully a fifth of the population of insane asylums in the United States were actually experiencing late-stage syphilis and this general paresis. So there was actually an approach where patients in this condition were deliberately affected with malaria. It sounds very challenging, but it's important to realize that it was the end of your life at this point. If this was the diagnosis that you received of general paresis, then that was it. You were never returning to mental function, and your life was over. So physicians noticed that when patients in this condition experienced fevers, that their symptoms would subside, that they'd return to something closer to normal function. So researchers at the time decided to try exposing these patients deliberately to malaria, because one of the primary symptoms of malaria is a recurring high fever. Actually read a study published in I believe it was 1919, studies of 9 patients and their outcomes. And 3 patients were actually able to return to normal life, so they were considered cured. Another 3 patients, so we're up to 2/3 now, experienced significant improvement. 2 patients experienced no improvement, and then the 9th patient died from malaria. So there are definitely some real concerns looking back at this from a 21st century perspective, but keep in mind there really were no other options available at the time. We actually saw a similar approach used in the early stages of HIV research. But of course, knowing what we know now about the disease, it's not really a surprise that HIV patients exposed to malaria ended up dying. So in the mid-20th century, we see the discovery of antibiotics that cured syphilis, and we see this whole idea of general paresis and any kind of treatment being required becoming much less common. Other ways that we used to treat mental disorders included narcosis therapy, which is basically using a narcotic or depressant to induce sleep in the patient for at least a week, thinking that if they were able to get some rest, perhaps they'd be able to recover from their condition. Of course, there's some serious flaws here. They'd still return to their life in the circumstances within it, and any physiological causes for the disease would not have been addressed. We also saw the use of truth serum during psychotherapy or talk therapy to help patients express repressed thoughts. Didn't really see significant improvement with either of these. And then insulin shock therapy was used to treat schizophrenia unsuccessfully. And then ECT, or electroconvulsive therapy, also found to be ineffective with schizophrenia, but it's still used today, despite perhaps some cultural perceptions of it being a cruel treatment. Definitely used that way in the past, but under the right circumstances for severe depression, it can be the only productive treatment available for people in that situation. So still used today under limited circumstances, and definitely in a different kind of setting than we may have seen portrayed in the popular media about historical uses of ECT.